Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcasts, Spotify, Google Podcasts, Stitcher Radio, and other platforms. Today was a busy day for me, not because I was seeing many patients in clinic, but because my schedule were two tough workouts, a 2,300-yard swim and a 35-minute run. You see, a few months ago, I had the crazy idea to train for a triathlon, a sport that involves swimming, biking, and running. As I trained, I noticed that the knee pain I had when going up and down the stairs of our house was gone, and my mood and energy also improved. As a rheumatologist, I tell virtually all of my patients to engage in regular exercise, as I think it provides one of the best returns on investments in terms of health and wellness. However, many people with rheumatic diseases face barriers to increasing their physical activity, often related to pain and fatigue. Well, in this episode, we'll clarify some common misconceptions about exercise for people with rheumatic diseases. We'll discuss tips and strategies to increase physical activity for people of all ages. We'll explore who would benefit from physical therapy or occupational therapy. We'll discuss bracing, taping, and other strategies that people may use to reduce pain and improve function. With me are two amazing and experienced guests. Dr. Kim Steinbarger is a physical therapist and assistant professor at Husson University in Bangor, Maine. She developed rheumatoid arthritis just a few years after becoming a physical therapist, so she has over 30 years' experience in managing her own disease as well as that of other people with rheumatic illnesses. She's the chair of the practice committee for the ARP, and she sits on their executive committee. Kim also manages the Soaring Eagles Healthcare, which is a pro bono clinic that provides physical therapy services to the uninsured and the underserved in the Bangor area. My second guest is Talitha Black, who's an occupational therapist who has had 18 years of experience treating children at Children's Hospital Los Angeles. She specializes in the care of children with rheumatic diseases and is also involved in their pain rehabilitation program at CHLA. She's a patient educator and advocate, a volunteer for the Arthritis Foundation and Scleroderma Foundation, and the Association of Rheumatology Professionals. Talitha currently serves on the ARP Membership and Nominations Committee. Let's get on with the show. Talitha and Kim, welcome to the show.
Hi, I'm very excited to be here, and thank you for having me.
Thank you for having me.
I think when patients come and see me in clinic, the last thing that they want to do is exercise because their joints hurt. What should I tell them? Is exercise a good thing for people with rheumatic diseases?
Absolutely. Send them to PT and OT. You don't have to tell them anything. Just send them our way. We'll take care of it. It is hard because you're tired, right? You have RA, you're tired, your joints hurt. Last thing you want to do is run around, right? But it's so important. And it's got to be individualized too. So you have to, that's why PT and OT is so important. So we can kind of walk through their life with them and figure out where they can fit that physical activity into their lives.
Great. And you mentioned physical activity, and I know, Talitha, you're an occupational therapist. Can you explain to me what the differences are and when patients should think about seeing a physical therapist or an occupational therapist?
Sure, I'll let Kim talk about physical therapy, but I can talk about occupational therapy. So we focus a lot on the activities that you do every day. So if you're having trouble getting dressed, having trouble taking a shower, making dinner, whatever it is that you do through your daily activities. This is somewhere OT can usually help. We can also help figure out your schedules and routines and how to integrate the things you want to do better into your life. A lot of OTs, but also some PTs who are hand therapists work on hand skills. So if you specifically have issues with your hands, that's somewhere that OT can help.
Yeah. And Kim, what about physical therapy?
So physical therapists are movement specialists. So, anything that requires movement, which is everything, right? We can help with. We can look at the joints and look at the muscles and look at your strength and your range and try to figure out how to make those things better in order for you to meet your goals. Whatever they are, whatever your, functional daily goals are, we can kind of break down all those components of movement and figure out what movements you're missing, what you need to capitalize on, what do you need to adapt, and kind of go from there.
Great. Let's start a little bit with more details, starting first with the children. So the ACR guidelines for, the treatment of JIA does conditionally recommend physical therapy and occupational therapy in addition to concomitant pharmacologic therapy. So, my first question is, who should I send to OT? Is it every child? Is it children that have joints with restrictive range of motion? Because, I know that some physicians that I know, think that kids get exercise all the time when they're running around and that maybe PT and OT aren't necessarily needed.
That's something I've heard before as well. So what I like to say is if it's a new diagnosis where the child has joint symptoms that can potentially get in the way of function or is already getting in the way of function, this is a good time to refer because we're going to do our evaluations and look at if the child needs ongoing therapy. So within our expertise, we can take a more detailed look at what's going on with the child and make that call. So if there's a child that really, if they have uveitis, you don't need to refer them, right? But if they're not showing any limitations, they're not having a lot of joint symptoms, it's probably okay not to refer. But if they start to have those later, get on it.
Got it. And are there any age limits? Like, should I send a 3-year-old girl with a swollen knee to therapy? Or, do they have to be a certain age in order to be able to cooperate?
There's definitely no age limits. We see newborns all the way up through age 21 at my facility. It's actually more important, I think, if it's a younger child that's trying to meet developmental milestones. Your example of a child who has a swollen knee, say they're 12 to 18 months at a time where most children learn to walk, it would be even more important for them to be referred for therapy at that time so that they can work on that knee and being able to walk at the right time.
So it sounds very challenging that, at the same time that children get afflicted with a rheumatic disease, they're also developing, right? So how does the rheumatic disease affect development? You sort of hinted that it could delay development.
Yes, this is something I talk about a lot because juvenile idiopathic arthritis is not considered a physical disability that by default causes developmental delay. And it doesn't usually affect cognition or anything like that, but effects on development should be considered. Like that example, if a child has a knee that's swollen and hot and hard to walk on when they're supposed to learn to walk, it's going to affect their development. So it's good to keep that in mind because it's not often considered assessed or addressed with kids with arthritis.
Great. And looking at the other end of the age spectrum with patients with RA in particular, it's interesting. I was reading the ACR guidelines about how to treat RA, and the current guidelines actually don't mention anything about exercise, but I know that the ACR is preparing a new guideline report working on integrative approaches to the treatment of RA that include, physical, psychosocial, mind-body, and nutritional interventions. So for adults, when should we think about referring adults with RA to a physical therapist?
So, John, I'm actually working on that guideline right now.
Oh, fantastic.
So that's been a learning experience for me. For adults, I believe, now this is probably like pie in the sky, but I believe that as soon as they get that diagnosis of a rheumatic disease or any kind of chronic disease, you should make the referral to PT and OT too. Because even if at that point in time they're not having a specific, like a hot joint or something like that, there are a lot of things that they need education on. I mean, they need to figure out what types of physical activity are good for them when they're having a flare. What should they do differently when they're having a flare versus coming out of a flare versus when their disease is inactive? They need those self-management techniques that I can give them. I can teach them these things. And so over the long run, they can be a lot more functional and they can learn to notice when they're having a decline. So they can come back to me and I can, like they have their physician, they can have their PT, they can have their OT, and I can kind of keep tabs on their disease activity. I can keep tabs on a lot of things. So I think as soon as that new diagnosis is made, it should warrant a referral.
Great. And let's talk a little bit about what's the magic that you guys do when you have patients referred to you. So Talitha, in a child that gets referred to you, how do you approach trying to figure out what it is that they actually need? And how do you set up the sessions so that they achieve the outcomes that you want them to achieve?
Well, everybody starts with an evaluation. So we don't just talk to the child, we also talk to the family, assuming the child can talk to us. So we want to get a picture of what their days look like, what they're able to do, anything they're having trouble doing, especially if it's something they really want to do, but they're having trouble with it. And we go through a process to set goals that work on what both the child and the family wants for the child. And I'm pretty sure this goes across the board for PT and OT. So we'll set up our sessions specifically around those goals. What steps do we need to take to meet them? And we'll definitely be active in our sessions. We'll try to, if the child says, I want to be able to swing at the park, we're going to set up a session in our sensory room that has a swing so they can try it out and figure out how to make it work for them. I'd say we have kind of a push and pull between adaptation and remediation, where we'll adapt things. So that same child who wants to swing, maybe she can wrap her arms around the chains on the swing so that she can do it right now, even though she can't maintain the grasp with her hands where she has arthritis right now. But later, we're going to still continue to work on getting her hands stronger and being able to hold on to things for longer so that she could swing in kind of a typical fashion. So we're working on both adapting and remediating kind of at the same time with the goal of her being able to participate as much as possible in what she wants to do.
Great. And Kim, how do you view adults? How do you make that initial evaluation and set up your sessions?
It's actually surprisingly similar to children. You're going to do an evaluation. You're going to look at the function that they have, the motion that they have, the strength that they have. And then you're going to have a conversation. I'm going to have a conversation with the patient about what can't you do right now that you want to be able to do? Or what do you see having trouble with in the future? And looking at, again, just like what Talitha said, what can we adapt? And what can we actually strengthen or stretch or whatever to improve function that way? So there's that balance. And trying to find that balance is very different for every patient. So I ask a lot of questions about what they do. What do you like to do? If I tell somebody to go exercise, I guess say, sure, yeah. I'm going to eat right too while I'm at it, right? And so, but I need to give them very specific instructions. And there's a lot of literature on this too, about being very specific to their life and what they like and what they would like to be able to do. Because, leisure activity, that's like the first thing that goes out the window when you hurt. And so, those are the things I want to know about. I want to know about what are they having trouble with at work? What are they having trouble with at home? What do they like to do? And how can we work all that in?
Yeah, it's interesting that you mentioned that. So, looking at the ACR guidelines for the treatment of osteoarthritis, they certainly recommend exercise across the board. They don't recommend a specific exercise, just exercise in general. And then they give the recommendation that it's more efficient if it's done under a supervised fashion, such as with a physical therapist. And they also want people with OA to get specific recommendations about specific exercises to do. Because I guess, as you said, if you just tell people to exercise, they're probably not going to do it. But if you give them more specifics, like, okay, walk around the block, every day, they may be better able to engage in those activities.
Yeah, and you're right. And it's baby steps, because if you tell somebody with, say, RA to exercise, okay, what they're thinking in their head is, oh my gosh, I've got to get ready. I've got to go to the gym. I've got to, put on my gym clothes. I've got to go swim or whatever it is I'm going to do. Then I have to shower. Then I have to take, and you take somebody who has a fatigue issue, which most people with rheumatic diseases do. It's too much. It's overwhelming. But if I talk more about physical activity, it's a little less scary, and increasing your physical activity by 5 minutes improves your health. 5 minutes. Every 5 minutes improves your health. That's from the World Health Organization.
Wow.
But I can give you an example. I had a woman who said, I said, what do you like to do? She says, I quilt. And I said, okay. And she goes, but that's really not very much exercise. Well, through more conversation, we realized that she uses a machine, like a quilting machine, and it takes up her whole garage. I said, how many times do you walk around that machine?
Wow.
We put a pedometer on her, and it was amazing how much physical activity she was actually getting. But if I hadn't asked, I wouldn't have known that. And it was something she enjoyed.
That's interesting. So you're thinking about building what I've heard referred to as atomic habits, right? Not tell them that they should go run a marathon, but sort of baby steps, how to increase activity for, 5 minutes at a time, and sort of as a way to start engaging in regular exercise.
Yeah, and it all counts. I mean, if you're vacuuming the floor, that's physical activity. If you're gardening, that's physical activity. If you're mowing the lawn, that's physical activity. It all counts. So making that more clear, I think, is really an eye-opener for some people to know that, oh, I am exercising. I just didn't know it.
Great. And can you guys talk a little bit about the different, sort of the menu of different types of exercises that are available? There's aerobic exercise, there's strength training. How do you think about all the modes of exercise, and how you recommend specific types to your patients?
I can start. It's a little bit different for kids. Some of the teens will do more classic exercises, but play is exercise for kids. And that's how they're going to get all their physical activity in. I know you mentioned, you hear people talk about how kids are just going to get it, so they maybe don't need therapy. The issue comes when they can't do it because it hurts. So for us, the menu is whatever they want to do, because kids are usually driven to be active. And I will say that most children self-limit. So if it hurts, they'll stop. Mm-hmm. So let them try everything. Just let them go. And without intervention from an adult, they're going to stop if they need to. But pushing their own boundaries also comes back to that development. If they're trying to learn a new skill, they're going to push their own boundaries. They're going to repeat movements over and over. And that's okay. You can let them do that.
Yeah, I feel like sometimes, especially for children, parents may be a little bit overprotective. And, I've had parents ask me, can you give them an excuse to get out of exercise at school because they have RA or JIA? And I'm like, no, they should engage, right? It's a good thing to engage.
Yes, this is super common in our clinic is, we produce school letters for the kids, especially when they have a new diagnosis, and we might recommend they have a 504 plan, which helps their school know how to adapt things for them. So what we really advocate is either having, depending on their level of involvement, adaptive PE. So they still have PE, but it's adapted for them, or having them have kind of a range of activities and participation based on how they're feeling that day. It's interesting because arthritis isn't well known to be in children. So sometimes we get a little pushback from PE teachers because arthritis falls into that invisible disease for a lot of kids. So the kids will be either marked down or called lazy, or the teacher thinks they're trying to get out of something. So we've made a few phone calls for that to the school. But most kids will want to do something. They don't want to sit out of PE. That's boring. They want to be in there doing stuff, at least below the high school age. Once they get to high school, it's a little different, but they want to be doing it. So if the teacher can provide a variety of ways for them to participate at different levels, we always feel that's way better than doing nothing.
I love that. So instead of, writing letters saying, please excuse this child from PEs, please find activities that this child can engage in during class. I think that sounds great. So Kim, what about in adults? What's the menu of options of different exercises that adults, can or should be getting to help improve, their joint symptoms and their rheumatic diseases?
Well, the guidelines say, now this is really overwhelming though for somebody that has a chronic rheumatic disease. The guidelines are, 30 minutes of activity, of vigorous activity, moderate to vigorous activity a day, 5 days a week, plus 2 days of strengthening exercises as well, which again, you look at those guidelines from the Academy of Sports Medicine and I don't know, even me. I mean, I have RA, I've had it for 30 years, and you show me those guidelines and I'm already exhausted and I haven't even done anything yet. So it's really important to get somebody to move. And if I can get them to move, I usually start with the aerobic. It's easier on the joints. And it's also, cardiac disease risk is so much higher as soon when you have a rheumatic disease. So you need to address that right away because that physical activity is good for people to keep them from developing cardiac problems, as well as, all the joint problems and everything else. But so I usually tend to go there first. You're walking, you're swimming, your housework, you're mowing the lawn, you're gardening, just that kind of just moving. And if you're crouching and you're getting up, there's elements of strengthening in everything that we do. So you can kind of mix it up a little bit. And kind of put both in there, but I do try to really make sure that patients realize that their cardiac risk has increased with that diagnosis. And so it's really important for them to move, not just for their joints, but for their heart, for their lungs, for their nerves, for everything, other systems other than the musculoskeletal.
Great. And does the type of aerobic activity matter? Like, if somebody has knee osteoarthritis, should they go running or would aquatic therapy be better? Should they engage in, popular these days is HIIT or the high intensity interval training? Is that a good thing or a bad thing for patients?
Yeah, I mean, the patients I see, some are athletes, some are not. It really depends on the patient. The high impact type of stuff, I know I tend to shy away from only because it does pound on joints that are already delicate. So that's where I usually will try to make a modification because, instead of running, could you ride a bike? Could you swim? Could you walk as opposed to, and try to find something that's a high enough intensity for whatever that person's needs are, but that will not pound on those joints because that can over time, hasten a deterioration. But exercise itself does not do that. It's just certain, you just have to be selective about what you're doing and make it fit the person, their life, and their pain levels and such. So it's definitely important. I don't want anybody to misinterpret that, but the type of exercise is something that PT can definitely help you figure out what you need and what works for you.
And you've both mentioned pain. So I've actually done PT several times. I've had stress fractures of my ankle, and certainly that caused pain. And when I had that, my body told me, okay, stop exercising because it hurts, right? And, allow it to heal, and then I would feel better. But I've also I noticed a while back, I was getting knee pain when climbing the stairs. And I'm not such an old guy. I was getting knee pain. I actually started running, and now my knee pain is better. So it seems to me that some types of pain, such as fractures, they may get worse if you continue doing that activity. But some other types of pain, perhaps like knee pain from osteoarthritis, could potentially get better if you work on your knees. Do you have any guidelines or suggestions about how you determine whether, pushing through the pain is actually a good thing and can actually lead to improved fitness and decrease pain after a while?
Well, that's another whole entire podcast, right? Because pain, there are kind of two types when you think about it. There's something we talk a lot about in the PT world is pain neuroscience education.
Yep.
And, pain, generally, you step on a nail, pain means damage, right? Is damage happening. And that's what we know of as pain. Pain is damage. But when you've got somebody with rheumatic disease, pain does not necessarily equate damage. And that's the understanding. You have to have a talk about pain with your patients, because with some patients who have had a chronic disease and pain for a very long time, pain becomes what we call centralized. And once it becomes centralized, that centralized pain, it spirals. It spirals up and up and up and up and up. And it's difficult to sometimes explain to somebody that the pain, it's a reaction. It's real. It's a reaction of their body because it thinks it's being damaged, but it's not. And teaching them to learn the difference between pain that's damaged and pain where there's no harm. I hurt, but there's no harm. Or I'm sore, but I'm safe. And being able to figure that out. When somebody starts saying things like, my knee won't let me, my back won't let me, those are some of the indications to you that their pain is becoming centralized and it's taking over their life. And there are things that we can do in PT to help try to flip that switch back the other way. And it's a lot of education.
Our previous episode, we discussed the use of cannabinoids for treating pain in patients with RA. And our guest brought up the idea of, I think she called it neuroplastic pain, which is sort of this new type of centralized pain that, as you said, Kim, doesn't necessarily reflect damage and maybe reflects more centralized process that can actually be overcome. Talitha, what are your thoughts about pain in children?
It's a lot of the same, and that pain neuroscience education is really, really key to help both kids and their families understand that not all pain means you stop. So you have to respect and notice pain, and especially if it's new pain, you've got to attend and try to figure out what's going on with it. But there's a lot of pain, and especially when you first start with new physical activity or exercise, there's a soreness that often comes along with it, which is a good soreness. It says you're working your muscles and they're getting stronger, and that soreness is part of that getting stronger. It's not going to stick around, but it's a sign that you're doing good exercise. One thing we use a lot is that in pain and in arthritis is that movement is your medicine. If you stop moving, you're likely to have more pain, more stiffness, more symptoms, more issues. So if you continue to move and you continue to work through whatever issues you're having being active, including pain, it's likely to get better. So we do approach, if there's pain that's amplified, which is more like that central pain, or pain that's kind of persisting beyond when you would expect it to, especially if it's for months at a time, we'll do a lot of what we call like a biopsychosocial approach. That's like the gold standard in all pain management. So movement is one component, but other strategies, in particular mental and cognitive strategies, are an important part of that. And that's what helps bring it all together. If you're only doing one or the other, it's not going to work as well as if you do it all together. Fantastic.
I just want to point out that if you listen to both what Talitha and I are saying, you really get a good indication of how PT and OT approach the same problem from different perspectives and how we work together. We're not replicating what each other is doing. We're actually doing different things, coming at it a different way to improve the patient's function. And I think what the two of us just said right now about pain was a really good example of that.
I love it. So I guess what you're telling me is that I should be referring all my chronic pain patients or kids with pain amplification syndrome, adults with fibromyalgia to PT and OT because you guys can definitely help. And it sounds like, a big part of what you do is education, right? Teaching them about sort of neuroscience, teaching them about how best to move their bodies and when it's okay to do things, even though they're having some pain. So when I write my script for PT and OT, what should it say? Sometimes I'm very lazy and I'm like, please evaluate and treat, which I'm sure you guys hate. What's the right way? What should it be on that script when I feel like some patients would benefit from your help?
Actually, eval and treat is just fine with me. I mean, in Maine, we have direct access. Somebody could come see me off the street without a referral. So I can eval and treat anybody. I think the game is the insurance game.
Aha.
And how you need to write it so that insurance will cover it. Because I know my own rheumatologist, I ask him this all the time. I say, do you refer right away? And he goes, no, I usually don't. He says, but it's usually because of insurance issues. And I don't know if I can get it covered. So I think that's the key, because I can do a lot of education but sometimes if they don't have like this joint right here hurts, I think insurances tend to poo-poo it, and I think that's the issue there. But eval and treat, I love.
Yeah, I would agree. Eval and treat is wonderful because it gives us the freedom to just do our own complete assessment and kind of decide where to make our focus with the patient and family. So that's helpful. One thing I would love to see on prescriptions that I don't always see is any specific restrictions that the doctor has. So, if they have TMJ arthritis and they're not supposed to do something in particular, I want that on there so I know what our parameters are, because otherwise I'm going to assume there aren't any. But the patient and family thinks there are.
Yeah,
so
yes.
It's great if it's nice and clear, either no restrictions or what those restrictions are recommended by the doctor.
Fantastic. Well, what's the role of bracing or taping? Is there a role for people to use those things, for a short period of time or for a long period of times? How do you guys view those additions?
I do a lot of bracing, particularly for hands. I would say the role is if it's a bridge to function, that's where we would use it the most, at least in OT. If a child can write for an hour at school compared to 5 minutes without the brace, because their wrist hurts when they're writing, then of course we're going to use a brace. But again, it's that remediation versus adaptation. We're going to work toward not needing the brace. So it's a bridge to somewhere most of the time. I know with some of my older teens that might have more joint damage that's not going to be reversed, some of that bracing may become more long-term, but for the most part, we're using it as a bridge.
Got it.
And I don't do a lot of bracing, but I do tape. I do some taping. The literature's mixed on it, but it's easy to try. I mean, it's a piece of tape, right? If you use some of the athletic tape like you see in the Olympics,
yeah,
you can use it. Sometimes you get some astounding results on swelling and pain by putting that tape on the skin, and that movement of the skin actually helps kind of tamp down the pain. And so I've had some people, I try it and it doesn't work. And then I have other people, I try it and they think it's wonderful. It's inexpensive. And again, if it doesn't work, you just pull it off. It's something that I've had mixed results with, but I'm always going to try it because it's something that's really easy to try and really easy to do.
Yeah.
And a patient can do it themselves once I teach them how to do it.
Great.
For taping, we use it a lot as a cue. So kids might get into like a maladaptive movement pattern. Say their wrists are really swollen all the time, so they keep them flexed, which is not a great position for strength in your hands. So they start to do things with their wrist flexed all the time. So I might use a kinesio tape or a stretchy tape to pull their wrist back, so it's a little uncomfortable to stay in that flexed position. So it gives them a cue to keep their wrist back once they're able to, and maybe the swelling has gone down. And it kind of gets them out of that movement pattern that was for something that they don't need anymore.
Yeah, that makes a lot of sense. And I guess another issue that I've had when I send patients to PT or OT is that when they're doing the exercises, they feel great. And then several months go by and then they tell me, Doc, my back is starting to hurt again. And I asked them, well, are you doing your PT exercises? Oh, no, I stopped when I was discharged. So do you guys have suggestions about how patients can help do the homework that you guys prescribe them during the course of PT or OT? And then how can they continue doing exercises or activities, once they get discharged from your care so that their function, remains good and that they don't fall back and need to start back from the beginning?
I think a lot of that's in the planning. I mean, that comes back to that autonomy. People need to want to do things because they want to do them and because they see the benefit. And if you can really show them the benefit and you can work the physical activity into their life, maybe it's something like gardening, like something they already do, or like kids with play. And it's not, I have to go to the gym and I have to, lift these weights 5 times. You have to work it into their life. And that's part of our expertise for PT and OT, is how to work it into their life so that it's not one more thing that they have to do, right? Because we all have to do one more thing. Maybe there's some stretches that they do before they get out of bed because they can feel the difference there. Maybe it's gardening, maybe we've adapted it a little bit so it's easier for them, but you've got to fit it into their life, and you have to also give them a plan going forward. Okay, as this gets easier in 2 months from now when you're not seeing me anymore, here's how you can advance it. Here's how you can advance it on your own. So you have to give them that future plan so that they can kind of take ownership of the activity.
Yeah, I'd agree. I feel like the core of sustaining anything really in your life is schedules and routines and accountability. And of course, that benefit in actually enjoying it when you do it, right? So I feel like we've covered the benefit and the schedules and routines. I feel like the accountability component can be a big part. So if, you have somebody who will check in on you at a regular interval and say, hey, how's that thing going that you said, you were going to stretch every day before you got out of bed, because it makes you feel better and you start your day off better. And they're saying, oh, yeah, I kind of fell off the wagon on that, but I'm going to start it up again because you've reminded me. So I feel like that accountability component can be really helpful.
I think that makes it a good case, Talitha, for having your own PT or your own, like an OT that you see every year. I mean, PT, we can do annual checkups just like you do at your doctor. We can do that. And I think that is a great way to be accountable, is if you always see the same person, like you always see the same rheumatologist or the same PCP. They know your story and they know where to hold you accountable for things. And I think that's really important, that consistency.
Yeah. I think it also makes an argument for like the interdisciplinary collaboration. So if the rheumatologist and the OT and the PT and any other person they're seeing for anything are in contact and all are aware of what's going on with the person, each one can check in. Hey, how's that stretching in the morning going? Whenever they see them. So there's multiple points of contact from multiple people in their care team.
I love it. Before we wrap up, are there any misconceptions about, physical activity or exercise that you want to clarify here before we wrap up?
I think mostly for me, it's when you have a flare. And when you have a flare, it's important to keep moving. And that's why part of your exercise or your physical activity program should include, what do I do if I'm having a flare? Because you can't stop moving. You're just going to move differently when you're having a flare. And there should be a plan for that. And that's something, again, with your physical therapist, your OT, you can make that plan because we know it's going to happen. It's a cyclical disease. It goes up and down. You're going to have a flare at some point, and you need to know how to handle that and how to come out of that. And I think, people are afraid they're going to hurt their joints if they do move them. You're actually going to hurt them if you don't. You just have to change how you move.
Yeah, I think that's a big one, Kim. The other one I'd like to hit is that there's a misconception that I've heard a lot that kids with arthritis can't or should not do sports. Definitely not true. One thing I do caution against, and our rheumatologists do as well, is contact sports. It's kind of similar to what Kim was saying about high impact exercise. It's not great on the joints already. And if you have arthritis in your joints, it's just not recommended. If you can avoid, contact football or boxing or things like that. That would be great. But most kids, and I would imagine a lot of adults as well, can participate in sports. They may need some adaptations. They may need some allowances for rest breaks. But especially with mild disease and advances in treatment that really reduce the physical effects of arthritis, many can participate at a normal level in sports.
I have a softball practice actually in 2 hours, and I've had RA for 30 years and I'm old on top of that.
And, there's certainly professional athletes that are doing commercials about, biologics for rheumatic diseases, and they seem to be at the top of their game. So that's a great place to end that, I think reflecting that for most, children and adults with rheumatic diseases, they should be encouraged to have activities, play sports, even at a professional level, perhaps not tackle football, but almost every other type of exercise out there, is going to be a good thing. And as you mentioned, it seems that not moving the joints is when you get into trouble. And the more you move the joints, the better they will be. So Kim and Talitha, thank you so much for joining me with this podcast. I really appreciate your time.
Thank you. It was a lot of fun.
Yes, I enjoyed it. So thank you very much.
Thank you all for listening, downloading, and subscribing to ACR On Air. Be sure to follow us on Facebook and Twitter at ACR Room for updates that we are sure you will not want to miss. And now that the show is over, why not take a walk around the block? Go for a bike ride. Go for a swim. And as always, please stay healthy.